Good evening, everyone, and welcome to Online Shoulder and Elbow School. I am Juan Aguilar, member of the SECEC Junior Committee, and today we are hosting the second session of 2024. The topic is distal biceps lesions of the elbow. First of all, thank you all for joining us today. Many thanks also to Secretariat, to Maria and Swasig, as always helping us in the organization of these events. And of course, thank you to all the participants. I would like to introduce the 5 young surgeons participating today. We have an international panel with Maria Shiryaeva from Russia, with Krunal Soni and Ankit Jose, both from India, with Enrique Peces from Spain, and with Ilaria Zorzolo from Italy. These young surgeons will be asked some questions through clinical cases for discussion. The cases will be presented by 2 senior surgeons. The goal is to learn concepts that you don't want to miss in your clinical practice. The chat will be open for questions during the session, so everyone can participate. Only after the discussion of each case, the chat moderator today, who is Valentina Greco, my colleague from Junior Committee, will forward the most relevant questions to the senior surgeons for resolution, like in 5 minutes. I have the honor to introduce our 2 senior surgeons today, both worldwide renowned experts on elbow surgery. We are lucky to have with us today Dr. Alessandra Colozza, Chief of Orthopedics in Faenza Hospital in Italy and Mayo Clinic Elbow Club member, and Dr. Roger Van Riet from Antwerp, Belgium, who all of us know, who needs no presentation and is our SECEC president-elected. Thank you very much for being here with us today, and please, let's start the session. Please, Dr. Van Riet, you can start with your first case.
Thank you, Juan. Thank you for organizing this. So, as the session is on biceps tendon, it's no surprise that I'll be talking of biceps tendons, of course. I do have a conflict of interest. I'm a designer with Acumet, and I'm also the designer of this brace that you'll see during the presentation. So this is the first case. This is a 45-year-old male. He has a history of 3 months pain in the right anterior elbow, and this started after he moved house. He's in his new house. He still needs to do a lot of work for about a year or so, and he made sure that I knew that he needs to work. He can't take time off. So for the panel, who wants to start? Any other questions for the patient? Maybe Ilaria?
Yeah, I might not have catch it, but where does he localize the pain?
Anterior.
Just on the anterior, so, and he doesn't have any instability? No instability. As for, there is some type of activities that get the pain worse?
Okay, that's a good question. Yes, when he's trying to rebuild his house.
So after long prolonged activity, or just
yes.
As he start to move?
And no, prolonged activity.
Prolonged activity. Does he have any cramping?
No, not really.
No cramping. And does the pain irradiates along the forearm?
Yes, a little bit sometimes.
Sometimes, but it seems like a nervous pain, like some entrapment nerve pain, or
could be.
Could be, okay.
But no pins and needles. No
pins and needles.
Numbness,
so
no numbness, no pins and needles. Just a vague forearm pain.
Vague forearm pain. Okay. That would
Any
be.
Other question?
Before that, can we inquire a little bit about history, whether there was any history of any traumatic event or lifting anything heavy or putting something down?
Yes, not really. He was lifting for a long time because he was moving house, but he didn't really remember one event where he thought it was worse. It just sort of gradually appeared.
And can we inquire maybe about some personal history about smoking or about being on any anabolic steroids or corticosteroids, which are a risk factor for maybe age-related subdegenerative changes?
Yes, great questions. No, he doesn't smoke. He doesn't use any steroids. No antibiotics lately.
No antibiotics
recently.
Was the other question.
Any history of diabetes?
No
any
diabetes.
History of any systematic illness?
No. Good questions.
I would like to know what is the dominant hand? Is it the right hand or the left hand?
Great, right hand. It's his dominant hand that's painful.
What is the activity of daily living he is limiting with this problem?
Mainly his house. So he works in an office. He doesn't really use his arm during the day that much, and he's happy with his professional life. But because he bought an old house and he wants to redo it, like the bathroom and all that stuff, he's having trouble doing this. Pain. He's still doing it. It's not stopped him from working. He's still working, but it's painful.
Maybe any history of any popping or any audible snap which he heard in.
No.
Nothing. No. Any weakness in flexion or any weakness in supination, routine movements like screwing?
Yes, but mainly when it's painful.
Mainly painful. Okay.
Yeah. So it's the pain that's stopping him from doing it, but not necessarily not necessarily a lack of strength.
Okay. And has the pain decreased, been the same, or improved over some time?
Yes, every time he rests, the pain is gone. And every time he does stuff, the pain is back. And then sometimes even in the morning when he wakes up, he has some pain as well. But it's bearable, but it's painful.
Also, because of his age, we would like to know if he had any complaints in his elbow since last couple of years to rule out any arthritic changes, maybe.
Yes, nothing.
Nothing. Okay.
Maybe I'll continue. I think we've been over most of it. Tearing or bruising. So you already asked that, whether there was any pop or anything. Pins and needles. Ilaria asked that no pins and needles. Painful activities. So when he's doing his house, arm dominance. The one that I missed, was there any previous treatment? Many patients come to us with already have been to a physio or to a doctor or took some medication. And then if there has been any imaging, I think that's an important question too, because if someone else has already done MRI or ultrasound or whatever, maybe you don't want to repeat that. Or coming back to your comment just now, if there was an X-ray for osteoarthritic changes, we would have seen that as well. Smoking, sports, health concerns, we've gone over that. So I think you covered everything that I was thinking of as well. So what's the pathology? What are you thinking about?
So since no pins and needles, I don't think an entrapped nerve. So I would exclude that, and it still might be some tendinopathy or some arthritic changes to the joint. That might be inflammatory or post-traumatic. Well, I know that he didn't have any major trauma, but it might be some arthritic changes or an inflammatory disease of the joint.
Okay. I agree with all of them except for the pins and needles. So you can have a posterior interosseous nerve entrapment, and patients with posterior interosseous nerve entrapment have a very similar history like this, but don't have pins and needles, because posterior interosseous nerve is only a motor branch of the radial nerve. So we'll talk about that maybe in a second. I didn't include it, but I think it might be a good teaching point. Anyone else, maybe more specific? What are you thinking of?
I would like to know in the examination, Roger, is there any deformity in the arm, or is there any bruising? What is the examination?
Yeah, we're going to come to the examination in a second as well. But is there anything from the history? Do you think from the history, what are you thinking of?
So looks like either a medial epicondylitis-like picture, or maybe some pathology related to distal biceps.
Oh, finally, yes, biceps. I had this slide here, Captain Obvious. The whole session is about biceps, so I thought you guys would say biceps immediately, and I think I shouldn't have shown you this before we started. So yes, it's biceps, obviously, and it can be bursitis, can be tendinopathy, can be rupture, and a rupture can be partial and complete. And I think you went over all the differential diagnoses very well, and maybe the posterior interosseous nerve we talk about if we have time, but definitely this is a biceps tendon problem. So this is maybe Enrique for you, a general exam of the elbow. What are you thinking? What are you looking at? You already mentioned Popeye sign, you mentioned bruising and all that stuff. So what else would you do in a general exam?
Yeah, first of all, I would like to know if there is any deformity, any reverse Popeye sign, You can also palpate the antecubital fossa in order to be the gap between maybe a rupture of the biceps. And you can also ask for the movement and be sure that is weak or pain in supination and flexion. And you can maybe be focused on the supination, and especially in the some specific test. You can I would do the hook test. Especially if the lateral side of the tendon. Otherwise, you can touch the lacertus fibrosis, and maybe it's a false negative. So also, it's important to do in the lateral part. And yeah, that's the main specific maneuvers for the distal biceps.
Yes. Okay. So clinical exam, always with every elbow problem. We went over differential diagnosis. So if you think about that range of motion, resisted movement, you already mentioned flexion and supination. Do nerve testing. What I do for the posterior interosseous nerve is I ask the patient to put the elbow in the side, then 90 degrees of flexion, and then supinate against resistance for a prolonged period of time. And what happens is when you have a posterior interosseous nerve problem, after about 20 seconds, 25 seconds, patients feel the burning. It's typical burning pain in the forearm, and they become weak and they start shaking a little bit. And that for me is a positive test for posterior interosseous nerve. Whereas as soon as you do resisted supination, it starts being painful immediately. That's probably not the nerve. That's probably more related to distal biceps. So specific biceps test, you already mentioned the hook test. Anything else?
A bicep squeeze test, a Roland's bicep squeeze test, in which the examiner would support the elbow in maybe 70-80 degree of flexion, fully pronate the forearm, and try to squeeze the distal part of the biceps. If we are not able to elicit any supination, that becomes a positive test, and that suggests that it is a distal biceps tear.
Just passive pronation of the forearm. If you see movement in the biceps, then it usually doesn't have a complete tear.
Excellent.
And the distance between the elbow crease and the muscle belly can be measured and see if there is a difference between the two sides.
Very good. Do you think any of these tests will be positive? In this particular patient, so
No.
So they will all be negative, probably, yeah.
In pronation, you can maybe the patient has pain in the pronation and forced pronation because of the provocative test. So maybe it's pain in full pronation.
Okay, so we already talked. I don't like the I don't like reverse Popeye sign because it looks like a shoulder surgeon. So actual Popeye is like this. You look at the shoulder surgeon stole this from us, but it's the Popeye sign is distal biceps. Resisted flexion, even in an acute complete tear, resisted flexion is still quite strong because the brachialis helps the flexion. Resisted supination will be very weak, especially when you test left and right. The hook test, we already heard about the hook test, where you have the patient. John O'Driscoll describes it very easily. He's one of the best teachers. So you ask the patient to look at their own hand, and then, as you said, from lateral, you try to hook the biceps. Initially, 20 years ago, he described it from medial, and then if you do it from medial, the lacertus may be intact, and then you get a negative hook test with a complete tear. But when you go from lateral, the hook test will either be in a complete tear, like this patient. The hook test will be the biceps will be absent, and the hook test will be positive. There's some bruising there as well. Or in a patient with an intact lacertus, the biceps may still be there, but it will be very weak compared to the other side. It will be very soft. Rotation sign, Ilaria already told us. We rotate the forearm. That's what happened with this guy. So passively rotate the forearm. Nothing happens to the biceps. If the biceps then is still intact, it will go up and down. The squeeze test, like the Thompson sign in the ankle. If you squeeze the biceps, the forearm should rotate. There's a lag sign and then bicep squeeze interval, more or less the same. So we did all these testing and everything was negative, except for there was mild pain with resisted supination, and the palpation was very aspecific. I tried to push it, tried to pull it, nothing. Everything was a little bit painful, a little bit okay, and all the rest was negative. So, do you know any specific? Oh, sorry, that's the answer. The specific test for partial distal biceps ruptures. These are the three, and I'll go over them then. These are the answers: tilt test, resisted hook test. And the distal biceps provocation test, which I still think should be called Antwerp biceps test, but unfortunately, American Journal of Hand Surgery didn't allow that. So the tilt sign, it was described in 2018. It's only 3 cases. It was a descriptive study, and they said that when you try to palpate the bicipital tuberosity, it will be more painful in pronation and less painful in supination. Then the resisted hook test, Michael Shimchuk published this in 2021. It was actually an abstract from SECEC conference in 2020. Together with O'Driscoll, they looked at 45 complete tears, 21 patients with a partial tear. 6 of them had an abnormal hook test, so either a very soft and not the loss of tension of the biceps, and 15 of 21 had an abnormal resisted hook test. And what they did was they asked the patient, so you go for it, the hook test is normal, then you ask the patient to resist supination, so you hold onto the hand and resist supination, and then when it becomes painful or weak or abnormal compared to the other side, then the resisted hook test is positive. They mentioned a sensitivity of 100% and specificity of 98%, so excellent numbers there. Then we described the distal biceps provocation test in 2 parts, elbow in about 70 degrees of flexion, hand of the examiner on the forearm, not on the wrist, that's important, and hand and wrist remain relaxed. And then you ask for resisted flexion with the forearm supinated and resisted flexion with the forearm pronated. And the resisted flexion with the forearm supinated is always less painful than with the forearm pronated. And this is something that I think everyone should remember, not necessarily because it's my test, but this is what happens. In supination, the painful part or the pathological part of the distal biceps tendon will be close to the tuberosity, so will be against the bone. In supination, it opens up, so it's not against the bone, so on the green side, not against the bone, and it's less painful. When you pronate, you're actually compressing the pathological tissue against the tuberosity, and then it becomes more painful. This is an endoscopic view of the biceps tendon, the same patient, on the left in supination, on the right in pronation. So on the left, the pathological area just slides away from the bone and it's not that painful. Again, clinically and schematically on the drawing and in real life. Then we looked at all 3 tests, and we found that the distal biceps provocation test was slightly better than the resisted hook test, and the tilt test didn't really work for us. It was 50-50. So we stopped doing the tilt test, and what we do now is we combine the resisted hook and the distal biceps provocation test together, and we found that if we combine them together, both sensitivity and specificity were extremely high, and we're very confident that we can now clinically diagnose distal biceps pathology besides a complete tear, of course. So this is partial tear, burst sites of tendinosis. Okay, for the panel again, what do you think about imaging? Which one would be helpful?
Ultrasound imaging.
Ultrasound?
Yeah, MRI also.
Mm-hmm.
I think, but it's not so special, I would say. I would prefer ultrasound, yeah.
Okay. Well, and when you do if you would do an MRI, Maria, which one would you do? Would you do a normal MRI or special MRI?
Actually, we don't have many special MRI, so no, normal one, I would say.
Normal MRI, okay. Yeah. Anyone else?
Special MRI with a special positioning of the arm in maybe flexion, abduction, and supination with the patient lying prone, so that we get a good view of the entire biceps going right to the tuberosity.
Yes, so that's a so-called FABS view.
Yeah.
I agree with both of you. I think ultrasound is excellent if you have a good radiologist, or if you do it yourself, maybe. Does anyone of you do it yourself?
Yeah, we do.
Yes, that's excellent. Yeah, unfortunately, I can't do it either, but that's a skill I'm missing, because I think that's the best way. If the orthopedic surgeon can do the ultrasound themselves, I think that's the best way, although there may be a slight bias, of course. MRI, these are the two ones I was talking about, Maria. So that's Superman view, where your arm is like this, and the FABS view is flexion, abduction, supination. That was first described by Guiffre and Moss, and I always thought they were French, but they're Australian. And they described this FABS view MRI, and basically you have to tell your radiologist or the technician at least how to do it. And this was on the left, the guy in the picture is not a patient, it's one of our technicians who's showing us how to do it. And the advantage is that you get a really nice view of the entire tendon together with the muscle. So then we thought, okay, maybe FABS view is probably the best for the biceps because it actually feels better to us. And then we looked at, we asked our radiologists to look at FABS views and at normal MRIs or Superman views. And they found that sensitivity and specificity didn't really change that much. It was definitely not significantly different. So if you want to just diagnose distal biceps pathology, it doesn't make a difference whether you use a FABS view or not. I'm looking at the time, so we need to go on a little bit, I think. So what it did help with the FABS view was that it was more reliable on diagnosing the extent of the tear. So if you want to know whether it's a small tear or big tear, then a FABS view helps a lot. So treatment, we'll go over this. Conservative treatment versus surgery, of course. Resting, maybe. Physio, maybe. Medication, maybe. Injections, no one knows. There's really literally no literature on all this, even though we say to the patient, rest it, or maybe go to the physio, or maybe even we do an ultrasound guided injection. We don't really know. This is an important question. If you do surgery, so big if, so no one knows the natural history of distal biceps tendon, of partial distal biceps tendon tears. We know that every expert says wait 6 months, because in 6 months most people will heal, and if it hasn't healed after 6 months, you probably need surgery, but no one knows. And in my practice, I actually recently had a patient who had a distal biceps tear, a partial distal biceps tear, that went on to a complete tear 7 years later, and he's the only one as far as I can remember. I cannot remember another case where a patient with a partial tear actually came back with a full tear. So when do we do surgery? I think I already answered that. 6 months, maybe, yes or no. And then the options. There are several options for this. When we do surgery, what do you think?
If the tear is just minimal, you might just debride the tissue.
Mm-hmm. Yes, that's a good one. And then you can do that endoscopically or open. Endoscopy is actually more or less the same as open. The difference is that it gives a magnified view, no tendon manipulation, and like I said, you can look inside. And this is our algorithm. So when there's a burst site, there's tendinous or partial tear 0 to 25, and that's where the FABS view is important. We debride. If it's 25 to 50, we repair with an anchor. And if it's more than 50, we just detach it and pretend that it's a big tear, a full tear, and then we just do an under button repair. The nice thing about this is that with partial rupture, you can always palpate the biceps tendon because it's still there. We make an incision. The incision for me is exactly the same as open. So we get 2 centimeter incision, about 3 centimeters from the elbow crease. You go down, look, yes or no, look at the antebrachial cutaneous nerve, but definitely protect it. I've stopped looking at it. I know where it is now, so I'm not looking at it anymore. And I found that since I don't touch it, I get less problems with the lateral antebrachial cutaneous nerve. If you do get a problem, it's not a big deal. It goes away. The feeling will come back, and they'll have numbness for a while. So just warn them they'll have numbness for a while, and they'll be fine. So this is what we see when you look deep into the arm. You see the tuberosity. On the closest side is where the tendon is. We debride the insertion. If you do this, whether you're an expert or whether you're a beginner, it doesn't matter. Use retractors. You see on the corner of my image, there's a retractor there. Make sure that you have retractors, or use there's a Deepak Bhatia from India. It has a different approach to distal biceps endoscopy. He's a very good surgeon, and what he uses a cannula. So his instruments don't go in without any protection. He has a cannula which acts as a retractor, of course. And the shoulder surgeons do this much better than I do, but you can tie the knot, put an anchor in, tie the knot. So this was a tendon that had a 25 to 50% tear. Actually, it looks really good when you do it, but it takes a long time to heal. Post-operatively, we use an exosplint. Like I said, I have a conflict of interest there. I tell them to remove it minimum 15 minutes, 5 times a day for about 2 weeks. Full range of motion is allowed after 6 weeks and loading after 3 months. And in our series, we had 5% where we needed to convert to an end button repair because they remained painful. Maybe quickly, this is a second case, 33-year-old male professional athlete, injured his left arm boxing. And this is a very important question. What's the difference? Because we haven't touched on this yet. This may be the last question that I'm going to ask as we looked at everything else. What's the main difference between a partial rupture and a complete rupture in the clinical history? So the patient comes to you and the patient tells you his history and what's the main difference? Besides, there's a trauma and there's a sudden injury, I guess. What's the main difference?
They will have very subtle signs of pain. They would not have so much pain. And
yes, less pain.
The weakness would be lesser in comparison to the complete tears.
Less pain. I'm sorry, I see a typing error in my sentence, so I'm going to move on this one very quickly because I hate that. Clinical history. The main difference is this: the patient knows. Patient knows. Listen to him. Okay. I tore my bicep. They know when it happens. They know it happens. And then they sometimes go to the GP, and the GP says, "Oh, that's no problem. We don't do anything about that because they think it's a shoulder." And but the patient knows when there's a biceps tear. But then there's all these tests: Popeye sign, resisted flexion, supination, hook test. All of them are positive. I think the hook test, if you do the hook test and it's positive, that's it. But all of these will be positive. The surgical options, we can talk about 2 incision, single incision. The literature doesn't show a huge difference between the two. There are slight differences in complication rates, where the single incision is a little bit more prone to heterotopic ossification and PIN lesion, unfortunately. And the double incision can give radial synostosis, and the fixation is slightly different. This is what we do. We use an endo button. I make the same incision as endoscopic. There's a slight difference. This was described by Greg Bain initially in 2000. What we do is slightly different. So I suture it to the tendon, really to the tendon, debride it after my endo button is on. That's a difference with the original description. Then we use a guide pin, just an endo button guide pin from the knee surgeons. Overdrill with 8 millimeter, overdrill with 4.5. So make sure that you drill the first cortex first, because as soon as you overdrill with 4.5 with the endo button drill, the guide pin becomes wobbly. It's no longer stable. Then go through to the other side, and always, and I can't stress this enough, hypersupinate the arm when you're doing this. Hypersupinate, because if you don't, then the PIN is really in danger. So when you start drilling your guide pin or do anything else, hypersupinate. Flip the button, take an X-ray, and that's it. Button is nicely against the bone. It's important to rotate. So as soon as you fix the button, rotate, because there's always some supinator or some soft tissue in between. And when you rotate, you'll find that it cracks a little bit and it settles itself against the bone. Patients are allowed to lift immediately from day one, 20 kilos from day one. I allow all of them to lift 20 kilos from day one, and full range of motion from day one. So this is totally different to the ones to what I described before, where with a debridement or with a partial tear, I do protect them. With distal biceps and the button repair, we do not protect them except for the 20 kilos. And I know that's safe because I have had patients like this one who can lift 20 kilos very easily, and they will do it. If you tell them it's fine, they'll do it. Thank you. That's it.
Prof, do you have any experience with suture anchors?
Yes. I don't use them. So suture anchors, if you use 1 or 2 suture anchors, in the end, the result is the same. So the literature doesn't show any difference between suture anchor and the button, etc. There is some minor problem with suture anchors, maybe because there's a little bit of creep. So you fix them to the bone and you do an onlay technique, and it has to heal. If you then start moving and start lifting, like I allow my patients to do, then you probably end up with some creep and it takes a little bit longer to heal. But after 1 year, the literature doesn't show a difference. So I really like the quick, because most of my patients are a little bit special. I really like the fact that they can move immediately and they can lift immediately, because that's what definitely athletes want. Normal people might want to wait a little bit, but most of my patients want to lift very quickly.
Because I few anatomical studies which said that biceps heal very good when they have a surface fixation. So
yes,
maybe only when we practice an onlay method, the healing is better when in comparison to the intramedullary fixation. So any comment on that?
Yes, I totally agree. When you look at the anatomy, and if you put the anchors, you have to put the anchors a little bit around so on the almost the posteromedial side of the tuberosity. So you will get a better anatomical healing of the tendon if you use suture anchors in the proper way. But like I said, it takes longer, and the literature doesn't show any difference in re-rupture. There's a slightly higher re-rupture rate with anchors, but it's not really significant. It's just a rehab that takes longer, and in the end, after 1 year, 2 years, there are no results, no differences between the two techniques.
Okay, thank you.
Roger, one question. Do you use also an interference screw in order to enhance the fixation or not?
That's a good question. So interference screws we don't use. I've never used them. I don't think it's necessary. First of all, it doesn't strengthen my repair. And Peter Kakebeke did a study where he showed that with interference screws, you actually had more tunnel widening, whereas with the endo button, we got tunnel closure. So in the long run, it feels like the interference screws are, I've removed a few, I had to remove a few. It feels like the interference screws is just an addition where you're not really gaining anything and you're gaining complexity and potential complications. So I've never used them.
Okay, thank you very much for such an interesting case and discussion. People have been participating on the chat, but I think all the questions have been solved. So thank you very much again, and we can move on with the next case.
Okay, thanks guys.
Quick question. Do you feel any difference between the long and the short head based on your fixation? Proximal and distal described. Do you feel that during putting a tunnel or reaming in an inlet technique, you can do a difference in the fixation? Thank you.
Again, that's a good question. Anatomically, yes. So if you want to be proper anatomic, you have to fix the long head and the short head separately. And Joydeep Fatnis has described some cases of only one head tearing. But again, in the end, it doesn't make a difference. The results of fixation are so good after 1 year, 2 years. There's 110%. So the arm actually becomes stronger in flexion, and you get about 95% of supination strength. So if you want to definitely increase supination strength, then you need to be anatomic, I think. And we're working on a new device that hopefully will support this. But at the moment, I don't think it'll be marginal gains, and hopefully we don't increase complexity and complications, like I said before.
Thank you.
Just to add to that question, when you're trying to recreate anatomically, you would focus more on the short head footprint or the long head, or you'll achieve a 50% between both. So what are you aiming more at? Supination, flexion, or both?
Well, both. If you want to be anatomic, you have to be anatomic. That's you can't be half anatomic, because then you might as well do the endo button.
Since we are talking about anatomic reconstruction, why not do the double incision Mayo technique? It's easier to reach the tuberosity. If that's the concern, then why not do the double incision?
Yeah, for me, it's not a concern, and I'll give you my honest answer. Is because I was trained by Greg Bain, and Greg Bain showed me the technique, and I've been very happy with it, and I never felt the need to change, specifically because the rehab is so fast. Whereas in the Mayo technique, you still have to protect it a little bit. And you know, Dr. Mori had a biceps tendon rupture, and he himself had a double incision technique done by Sean O'Driscoll. But if my biceps is not very impressive. So if my biceps would rupture, I would definitely do endo button and nothing else, and just get it done.
If I can add,
Sorry.
I'm still using the 2 anchors. I use the soft anchors but the problem was related most to my administration because it wasn't allowed the endo button. So we're gonna move to the endo button in the future. But the most important point in the anchors is try to hypersupinate and protect the radial nerve on the lateral side. Don't put the levers on the radial side to protect the radial nerve. But if you stay on the distal, the tuberosity of the radius, and you can hypersupinate, you are not exactly anatomical, but you're very close to anatomy. Of course, the major problem is you have to protect longer the patient. So we protect 3 months the patient. We don't allow to lift the heavy weights until they completely healed. So I will move to endo button as Roger said. So I will share my presentation. Let's go on to another topics. I will skip all the points that we already discussed with Roger. So this patient is 57 years old, is a manual worker. He has an acute history of pain. He was lifting a heavy weight, and he felt a very strong pain. He got an ecchymosis for a few days, but he kept going on with working. In my area, this happens very frequently. And he came to our office with an MRI 2.5 months after the trauma. So if you assume that this is a problem of the bicep tendon tear, what kind of clinical tests do you include in your examination for detecting the damage of this detachment of the tendon? Ilaria, what do you think?
Yeah, I do the hook test. Basically, that was I trust more, the most.
Sometimes in these cases in which the time between the injury and the examination, you can have a kind of fibrosis of the tendon. If the hook test is not clearly positive, do you have a way to have another test to check the continuity of the tendon?
Yeah, the passive pronation test and the distance between the crease and the muscle belly.
Okay, Roger already said us, if you use the resisted hook test, you can slatentize injury. In some instances, we are not able to understand if there's a continuity of the tendon. So if you have to the patient to resist and supinated making a forced supination, you tell to the patient, don't let me bend your hand. They supinate very strongly, and so you can easily touch the tendon or not to touch the tendon. So the diagnosis is faster. Okay. So if you are in doubt, you can ask to the patient to hypersupinate against resistance. Okay. And the test that we with Dr. Van Riet, do you think it could be useful, the tilt test on the distal bicep provocation test? Enrique, do you think it's useful to make this test in a case like the one we are talking about?
In this case, that you suspect a complete tear, maybe it's not very useful because you can the hook test and palpate the gap. The distal bicep provocation test maybe is for partial rupture. So if I suspect a complete tear, maybe it's not so useful.
So you suppose that the tests are negative, right? Because the tendon is not attached anymore to the bone.
Yeah.
Okay. So this is the clinical examination. It's pretty typical. So I don't want to focus on the diagnosis. The diagnosis is pretty pretty easy. So the range of motion is normal, a mild antecubital pain. The hook test and resisted hook test are pretty positive. We have a loss of supination strength. This is the main point where we are already focused with Roger on this point. So how do you classify this lesion? Is acute, subacute, or chronic? Ankit, what do you think? Ankit, are you still there?
Yeah, hi. Yeah, I
Okay.
would like to keep arbitrarily 3 weeks, but it's mainly the nature of the tissue, quality of the tissue that would more I'll be more worried about than the chronicity of the symptoms. And also the conditions, is he a smoker or diabetes, which may affect the tissue quality.
Okay, so your definition of acute, subacute, or chronic is based on the quality of the tissue.
Yes.
From the literature, we can say that chronic is based on the time between the injury and your observation. And in most of the papers, they tell us that is around 3-4 weeks, the landmark between acute and chronic. There's not a clear definition of subacute. Subacute could be between 10 and 20 days. But chronic is after 3 weeks. And, I don't know if your country is similar, but very often in Italy, the patient underwent ultrasound and then they wait for MRI. Very often we see this patient already with a chronic lesion. Okay. So in those cases, do you always ask for MRI? And what do you look for in the MRI? There's something specific that you're looking for in the MRI if you make a FABS or a normal MRI? Maria, what do you think?
Oh, okay. In case I have got a nice ultrasound image, I wouldn't ask for an MRI.
Okay. So you don't routinely ask for MRI in chronic. And
yes, we prefer ultrasound, but actually I can ask in what can I say? I mean, maybe scar tissue, and we can look for where is the tendon and where is the fibrosis tissue. In this case, maybe yes, but I would prefer ultrasound.
I agree with you. I mean, we are not so skilled with the ultrasound, but I think it's very useful also for understanding the continuity of the sartorial fibrosis. If you, in this case, in a chronic case, if you have a continuity of lacertal fibrosis, what do you expect? That the tendon is more or less retracted?
So I think it's less retracted. So
sorry, let's go on.
If you got a lacertal fibrosis intact, so I think it's the tendon is less retracted. It is okay, quite nice.
Is there anybody that wanna add something about the MRI findings in a chronic lesion? Krunal, do you look for something specific in a chronic?
Yes. So if there is a chronic lesion, I would ask for an MRI to see how much the tendon is proximally retracted. So and also that will give me an idea of whether this can be repaired, or this might need some tenodesis or maybe a graft. So yes, in chronic, I would ask for an MRI.
Probably Maria is very skilled with ultrasound, so she's able to give us the same information as MRI just with the ultrasound. So I found this very nice publication about the turtleneck sign. It was a publication from Dr. Driscoll. And as you can see, sometimes in a sagittal view, we can see this kind of shape of the tendon. And it reminds the neck of the turtle. So if this sign is positive, it means that the tendon is very retracted. We have a better chance, a higher chance to use a graft for the reconstruction. We can also measure in the sagittal view the distance between the radial tuberosity and the and the tendon. If we have this kind of signs, mean that the distance is more than 8 centimeters. In those cases, we have a higher chance to the need of the graft for the reconstruction. So if we ask for an MRI, if we were able to have the same kind of information by the ultrasound, we can have a kind of chance of understanding if we need a graft to reconstruct the bicep tendon. Okay.
Okay.
So this is the MRI of the patient. Normally, we can see the tendon in the axial view. In this patient, or in all the patient that we had that have this kind of tear, we have an empty space. So the diagnosis is pretty obvious. On this sagittal view, we can follow the tendon, and we can see we have a tiny tissue that connect the biceps to the tuberosity. And in these instances, we can understand that the tendon is not so retracted. Okay. So we have the patient in front of us. He's asking us, okay, doctor, I have no so painful. I have to work. I cannot stop for a while. He asks you some kind of information about the complication rate in a chronic lesion. Who among you is able to give a rate of the complication in chronic lesion? Krunal.
So if it is a chronic tear, the complication rates are significantly high and the outcomes are very unpredictable. So I would definitely counsel the patient a complication rate of as high as 20%, and the outcomes are not as predictable.
Okay, Ilaria, do you have some further information about the complication? Can you quantify to the patient?
No, not with a number, but it's a higher complication rate to have nerve damage, neuropraxia, than what is done in acute, since you have to debride the scar tissue. And
so the average complication rate is 41, okay, from the literature. So you can see in this paper, we have a range from 30 to 20, 21, 24 in acute is almost double in the chronic. So this is a very important information that we should give to the patient in terms of decision. And if we go through the complication, we have the minor, the lateral anticutaneous nerve transient paresthesia, as Roger told us, and a superficial wound infection, but we have major complication. The overall neurological complication are around 20%, but mostly are related to this nerve, so to sensitive problems. In between, among the major complication, we can have DHO formation, but the major complication are DHO that require another surgery to restore the pronosupination and the re-rupture. So about the question of the patient, which are the sequelae of my conservative treatment, if I decide not to undergo the surgery, what's the consequence for me? Enrique, what do you think?
I think you should say to the patient that the main sequela maybe is the weakness in flexion and supination. Maybe the main weakness is in supination if your brachialis is intact. But for me, it's the main sequela.
So probably you have to focus on the activity of the request of the patient in terms of activity and sports and work to understand if it really needs to have more supination, because we saw that the complication rate is higher. Very good. So do you think you always need an augmentation in chronic lesion? Is there, we have some information from the MRI, but is there any other parameter that tells you that you need a graft? Ankit, what do you think?
Mainly the amount of retraction of the tendon will be, and the chronicity of the symptoms will be a guide to decide on augmentation, and also the post-operative, if you don't augment in such cases, will there be any chance of getting a full extension? Is there a problem?
Maria, do you think you could be able to repair in chronic lesion a tendon to the tuberosity, direct repair? Is there any chance to do this?
Not in every case, I would say. But in most cases, we use like some hamstring autograft.
Okay. So we know from the literature, there's a very important paper from Dr. Mori. As you can see, it's pretty surprising, the data. So this paper changed my practice. So it was able to reach a primary repair in most of the chronic cases just by flexing the elbow. So the concern of the surgeon and my concern was related to the lack of extension in the post-op care and the follow-up. But at the end, you can see 19 cases were fixed the biceps more than 60 degrees of flexion. At the end of the follow-up, the extension lag was just 10, 20 degrees. So in most of the cases, you are able to fix the biceps to the tuberosity just by flexing the elbow. And do you think the time between the injury and the surgery can, in some ways, tell us if we need a graft? Do you think just the element of time can tell us if we need a graft or not? Ilaria, what do you think?
I don't think so, because if the lacertus fibrosus is intact, it might have not retracted that much, even with a long period of time since presentation. That would be my guess, but I'm not sure.
You're right, but we have studied a group with we did a multicentric study with around 60 cases. Strangely, it appears that after, if the time between the injury and the surgery is more than 3 months, very often we need a graft. So we're probably, I agree with you, and I think it's the most important thing is to check the lacertus probably by the month in some way that we have just also a fibrotization of the belly of the tissue of the tendon that cannot be completely repaired to the tuberosity. So if you need the graft.
Can I ask a question?
Yeah.
So in the previous paper, you said that even in chronic tears with extreme flexion, you would still do a primary repair.
Mm-hmm.
And in the next slide, you said that if it was more than 3 months, you would put a graft. So what was your deciding factor between graft and a primary repair then?
So normally we made the primary repair in chronic around from 3-4 weeks to 3 months. In most of the case, we are able to repair the tendon. Of course, the integrity of the lacerto fibroso is a very important factor, and the MRI study can give us more information. But in all the patients, I explained that I want to have the graft in the OR. So sometimes you have a surprise. I mean, if you have a chronic tear around 3 months, you are not sure, probably you will use the graft. And it depends on the retraction of the tissue, the thickness of the tissue, the quality of the tissue. It's just not a tissue that you have to reattach to the bone. You have to try to understand the thickness of the tissue, the quality of the tissue. Okay. So in the past, we were talking about the graft. Of course, we can use the Achilles tendon graft. Is published by Dr. Mori, but we can also use the semitendinous tendon or similar. We use the peroneus brevis. In the past, we used the lacerto fibrosus. We don't use it anymore because it is a kind of contradiction. So if the lacerto fibrosis is intact, probably I will be able to make a direct repair. On the contrary, if lacerto fibrosis is not intact, I cannot use it as graft, because in the past we used the technique just to elongate for 2-3 centimeter the tendon to reach the tuberosity. Okay, so the decision between using or not the graft is related to the quality of the tissue or to the retraction of the tissue. Okay. So if we go back to our patient, because we don't have time anymore. So do you think that it's correct to operating this patient? Do you think the graft is necessary? Maria, what do you think?
In this patient, so I will suggest surgery, but I'll also look at his comorbidity, if he is okay, if he has some chronic diseases, because in case he has got a lot of chronic diseases, it's not a good choice, I would say.
The patient is fine, is healthy.
Okay, yes, I would suggest surgery because he's a hand worker, so I think he really needs his hands to be okay.
Okay, I agree with you. So we made the surgery. We normally start from with a small incision to 3 centimeter on the tuberosity. We put 2 anchors, also suture anchor, as I told you. I will move to the button in the next future. And after that, after putting the anchors, we look for the tendon. Very often, if you are patient, you take some time to try to detect the tendon proximally. You don't need another incision. In some instances, if you're not able to find the tendon through this incision, you can make a more proximal longitudinal incision on the belly of the biceps. And after that, we refix with anchors the tendon to the tuberosity. In this case, we were able to fix it around 40 degrees of flexion. In this group of patients, we use an orthosis, a protection for a couple of weeks, 20 days. And after that, we start with a gently passive motion. Active motion is allowed. After 3 months, the patient is allowed to weightlifting. On the follow-up, the RAM was complete. The flexion supination strength was symmetric with the controlator. It just have a minor paresthesia on the lateral side of the forearm. And do you have any question?
I have a question. Angle of fixation was 40 degree in this case. Is there any, do you always prefer 40 degrees, or do you change it in patients with hyperextension with beatens more than in hyperlax patients? Thank you.
So you mean if I need more flexion, how do you treat the patient post-op?
Yeah. No,
Okay.
the angle of fixation, is it always 40 degrees, or do you change based on the retraction of the tendon or acute or chronic setting? Because in chronic cases, maybe increasing the flexion angle, as you said, gets you a primary repair. So how is your criteria to understand that?
Okay, if I see that the tendon, as in this case, as you can see in the picture, is pretty good, I push to the primary repair. My first choice is the primary repair. Otherwise, if the quality of the tendon is not good, I prefer to try to make the graft. Okay, so even if I have to flex the elbow at 90 degrees, in some cases I fixed with a primary repair and chronic a 90 degree of flexion. I changed my post-op protocol because I try to protect the elbow for 6-8 weeks, allowing the extension every week 10 degrees more. So in some ways we try to protect it, not extending completely the elbow in the weeks after the surgery. So I changed my protocol, but my first choice is try to make a primary repair. Okay.
Thank you very much for such an interesting case. It seems that we have more questions from the audience in the chat. We are running out of time, so maybe in 2 minutes, Valentina, can you tell us what's going on the chat?
Yes, exactly. I have 2 quick questions from the chat. for the seniors. So do you have some tricks to find the tendon in the OR in the both acute and chronic path? So if you have some tricks, I don't know.
I put a finger. I'm kidding. I put a finger. I prefer to use the finger instead a sharp instrument. It seems to be rude, but I prefer a finger against the skin. So
Okay.
don't go too much deeply. Roger?
Yeah, for acute, it's a little bit different. But in acute, what I do is I go to the tuberosity first to make sure there's no tendon left. And then you can actually, I do the same with my finger. You can actually follow very often, if it's the more acute, the better. You can follow the tract of the bicep, so you know where it went into. You go up, you have to be a little bit careful because there's some blood vessels over it. So if you're too rough, you end up with a big hematoma. And if you can't find it anymore, then stay under the skin. Maybe one more trick is that the tendon is almost always on the medial side. And I think, I'm not sure why, but I think it's because Lacertis, the biceps tendon ruptures first, and the Lacertis ruptures second. And I think it goes towards medial. So if you start looking at that, you find that almost all the time it's on the medial side. And flex the elbow, of course. So you flex the elbow so your finger can actually go underneath, like you do in the FABS view. When you're extended with the elbow, it's very difficult to find it. So flex, put your finger in, find a tract without pushing. You don't need a lot of force. Find a tract, and when you find the tract, then flex the elbow, and then you find the tendon. Then you place the tendon somewhere in the middle, so you know more or less where it is. Then put a retractor under the skin, and then find the tendon again with your grasper. So I present it first with my finger, but there's only one finger fits, so I can't really grab it. Present it with my finger, and then pull it with the whatever instrument I have.
Great, amazing. So the second question people from the chat ask is, do you have any preference of inlay versus onlay tendon repair? And if you notice some differences, if you practice both techniques?
So I was telling us, as I was telling you, I will move to endobaton. If my ideal choice will be to have endoluminal endobaton, so a monocortical endobaton. I know that Roger is working on it, and I think it's the best solution. So the tendon goes in the bone, is not on lay, is inside the bone, but I don't have to perforate the second cortical. I decrease the risk of have an injury of the radial nerve. So my ideal solution is to be endoluminal inside the bone.
Right.
Okay.
I agree, obviously.
Perfect.
Thank you very much. Thank you very much. There is no more time left. It has been a great session. So we hope to see you all in the next session in May. It's going to be about shoulder, about AC joint dislocation. We want to invite every junior surgeon to send the application to participate in the upcoming sessions. And you can easily find the link to the application in the junior corner on the SECEC website. And also you can enter now on the chat, and you can find the link directly to click and do the application. Lastly, thanks to all of you, and especially to Dr. Colozza and Dr. Van Riet to share your knowledge with all of us. Thank you very much, and good night.
Thank you, guys.
See you soon.
Thank you.
Thank you.
Bye.
Thank you, everyone. Thank you.